Hello everyone, my name is Dr. Sayantan Dey. I am currently posted in SNCU at Medical College, Kolkata. So just the other day we were referred a child who had severe neonatal jaundice. The baby was sent to us with a lab value of TSB, that is total serum bilirubin, of 28. When we repeated this from our own lab, we found it to be 31, which is extremely high for the age, and it's extremely high for any human being. As we know, adults can have a total serum bilirubin of almost less than 1. This baby had 31. And why is this very dangerous? Is because bilirubin can cross the blood-brain barrier and get deposited in the brain, which can cause BIND, which is known as bilirubin-induced neurological damage. And this is extremely critical because this can cause lifelong problems for the child. The most common cause of severe neonatal jaundice is ABO incompatibility and Rh negative pregnancy. Rh negative pregnancy is when there is a negative blood group of the mother and the baby has positive blood group. And ABO incompatibility is when the mother has a blood group of O positive and the baby has any other blood group, that is A, B or AB. On sending reports to our blood bank, we found that the baby's blood group was B positive and mother's blood group was already documented as B positive. So it was neither Rh incompatibility or ABO incompatibility. So now we were trying to find out what the actual cause was. But before sending any other reports, we had to go in for the definitive treatment of this case, which is double volume exchange transfusion. So what is double volume exchange transfusion? Double volume exchange transfusion is an invasive process in which we put an umbilical catheter both in the umbilical artery and the umbilical vein. Through the umbilical artery, we take out blood 20 ml almost at a time, and we push in reconstituted, that is 2 parts of PRBC and 1 part of FFP, through the umbilical vein, thus exchanging the blood. So since the baby's and the mother's blood group was the same, that is B positive, we asked the blood bank to urgently send us a B positive PRBC, that is packed red blood cells, which is the lal khun that we actually say, and AB positive plasma, which is the safed khun. And then we went in for double volume exchange transfusion. This normogram is the exchange transfusion normogram, the normogram that we use for finding out whether the baby requires an exchange transfusion or not. For the age of the baby, that is around 5 days old, as you can see, 31 is way above the normogram. The first black line being the line for term babies. So after completing double volume exchange transfusion, we continued the baby on phototherapy, and 6 hours later we sent a repeat TSB, and we found this time that the TSB was just 16. From 31, it had fallen all the way to 16, and we were all very happy. The next day, we got back reports which we had sent to the lab. There were 2 reports we had sent. One was a thyroid profile and another was a G6PD analysis. So the thyroid profile that we had sent came back completely normal. The other test, which is G6PD analysis, is basically a test to find out the enzyme levels of an enzyme called G6PD in the body. This is an enzyme which prevents the oxidative damage of RBCs. And if there is a deficiency of this enzyme, it can cause hemolysis of these RBCs and cause an increase in bilirubin in the body of the baby. So what we saw was really quite shocking, and the baby had a moderate to severe deficiency of G6PD enzyme. As you can see from this report, the baby had just 1.96 value of G6PD enzyme, where the normal was more than 6. So this baby was diagnosed as having inherited G6PD deficiency. So what is G6PD deficiency and how did this baby get this disease? This is actually an inherited disease and it is completely genetic. It is X-linked recessive in its inheritance, and that is why this mostly affects male babies. Another report that we had done was a CRP value, which we found to be elevated. It was 26, which was quite high. So this pointed to a significant infection in the baby, and the baby probably had this infection since its referral. And this was probably why the G6PD deficiency had flared up. We counseled the parents that there was an infection and we needed to continue the stay of the baby in the hospital. We continued antibiotics for 7 days. Blood cultures came out to be negative, and at the end of 7 days, when we repeated the TSB, we found that the TSB was just 2. So from 31 to 16 all the way down to 2, we told the parents that the patient was out of danger, but we still needed to counsel the parents about one important thing, which every child with G6PD deficiency has to know and their parents have to know. This is a list of drugs that the patient can never have in throughout his life, and these are the drugs which can cause an acute flare-up of this G6PD deficiency and cause massive hemolysis in the body. These are the drugs that you can see on the screen. So we told the parents that this child cannot have these drugs in his life ever, and we counsel the parents that the baby is now stable and you can take the baby home. So this is a video of the baby just before discharge. So this just goes to show that quick action in neonatal jaundice can make all the difference. For more such clinical cases, subscribe to the channel.